Okay, so today I'm sorry I'm not there in person with my colleagues Aphrodite and Fortis, but I'm at the centenary, the 100th running of Le Mans, and it's starting in a few hours' time. So I'm going to talk today about intracardiac shunts with associated arch anomalies, but primarily about atrioventricular septal defects, because they're the biggest diagnostic dilemma for us. I just can't see all my slides. So when I started cardiac surgery, about 26 years ago as a consultant, we used to do quite a lot of our arch repairs, AVSDs, as a single stage operation. And that was really based on the fact that previously published data tended to lead us to do that. I'm sorry, just moving my things away. So can't see my slides. So data that had been originally written by colleagues at Marie-Lenong Hospital in Paris had followed up 271 patients who underwent repair of a coarctation. And they found that whenever they did two-stage operations for some children with atrioventricular septal defects, that they ended up with a higher mortality rate. So they had a higher mortality rate in the two-stage repair, 47% versus a 23% mortality rate for single-stage operations. But I think really that operations were, the data was quite skewed towards more simple operations such as arch repairs plus ventricular septal defects, and not really arch repairs with complete atrioventricular septal defects, which are more difficult. So patients with complete atrioventricular septal defect and aortic arch obstruction really do present a particular challenge in management. The incidence is also quite rare, so the surgical experience in publications is quite scant. So if you're extrapolating favourable results and achievements from of doing a VSD, an arch repair, to doing a complete atrioventricular septal defect and an arch repair at the same time, I don't think those two things really match up, and because the atrioventricular septal defect operation is much more complex. So patients with relatively balanced atrioventricular septal defects typically undergo repair at about 6 months of age in the absence of an arch repair. And we do this delay in part because we're worried about the fragile nature of the atrioventricular septal defect tissue, AVSD repair tissue. And later repair at 3 to 6 months is associated with a very acceptable mortality rate of about 2% in many centres. But aortic arch obstruction and coarctation of the aorta in the presence of an atrioventricular septal defects happens in about 2 to 6% of patients with AVSD, and they may be amenable to a biventricular repair. And these patients then would be referred for intervention because of the aortic arch obstruction in the neonatal period. A reasonable treatment option for these young patients would be a staged operation with the arch obstruction repaired first, followed by an appropriate interval, a later repair of the AVSD. However, if there's a significant degree of atrioventricular valve regurgitation, then the primary single-stage correction of both aortic obstructions is complicated, but can still be undertaken. So let's look at 3 different clinical scenarios. So you've got a neonate who's got obviously severe associated aortic arch obstruction with good function of the common AV valve, but they present critically ill due to the ductus arteriosus closing. Well, initially what you want to do is you want to resuscitate the child with prostaglandin and possibly ventilatory therapy for associated low cardiac output. And then surgery is performed on a semi-urgent basis once all the secondary manifestations of low cardiac output have responded to treatment. A different clinical scenario would be a neonate or an infant with mild aortic arch obstruction with good function of the common AV valve. This child may be minimally symptomatic because of the physiological elevation of the pulmonary vascular resistance in the early postnatal period. And then surgery can be performed on a more elective basis, depending, of course, on the child's clinical course. And then the more complicated one is the neonate or infant with severe dysfunction of the common AV valve, a leaking AV valve, and with mild or severe aortic arch obstruction. Well, they can present pretty early on in life with symptoms of pulmonary overcirculation, congestion, and poor systemic perfusion and failure to thrive. Some authors have actually advised that these could be palliated initially by balloon angioplasty of the coarctation, or possibly even stenting of the coarctation. However, that's not really what we do in our unit. And if decongestive therapy fails, then surgery may be indicated on a semi-urgent basis. So the 2 surgical strategies can be considered. In the 2-stage approach, the arch obstruction is repaired first with or without pulmonary artery banding. And the hope is that that will improve the systemic perfusion and make a significant impact on the symptoms of congestive heart failure. And then correction of the AVSD can follow on in 2 to 4 months. If you've done a first stage where the arch has been repaired and the child is failing to come off ventilation, well, then they might need a pulmonary artery band, or if that's not working, then you might need to go on and do an intracardiac repair of the AVSD. Single stage or primary surgical correction of the arch and intracardiac with the AVSD can be performed irrespective of their age. And the timing of the operation is really driven by the clinical course, but it's usually required within the first few weeks of life. As I said, the decision making is challenging, and the critical issue is really whether or not there's significant AV valve regurgitation. If the AV valve is significant regurgitation, you can still try to relieve the arch obstruction by angioplasty or stent, or if there's no improvement with that, then you can place a pulmonary artery band, or a one-stage repair could be considered. It used to be, David, who's in the audience, we would have had an opinion for a long time that you wouldn't put a pulmonary artery band onto a child who's got significant AV valve regurgitation. But our recent experience of actually putting on pulmonary artery bands in children with AVSDs that have got regurgitant valves is changing, and it doesn't appear to be as bad as we once thought it was. So this is work and study, and we're looking at that at the moment to see if pulmonary artery banding actually can improve to a degree left AV valve regurgitation in a common AVSD. This is a good paper. It was a multi-centered paper from John Costello's unit, but there was 6 different cardiac centers over a period from 1990 to 2009. And you can see it's with 6 centers, they only managed to get 66 patients who had an AVSD and a arch obstruction. And they looked to see whether or not a primary neonatal repair of the AVSD and the arch or a staged approach had any impact on outcome. So those undergone an initial complete repair tended to have at least moderate more left AV valve regurgitation early after the repair, so 42% versus 19%, and also to have at least one major inter-hospital complication, so 42% versus 20%. After the initial cardiac operation, compared with the neonatal repair, patients who had the staged repair had greater survival at 6 years, so 87% versus 57%, and also a greater freedom from reoperation for unplanned cardiac procedures, 69% versus 45% at 6 years. But you can see that these group of patients are complicated, and even the other children who get the staged approach, 45% of them might need a reoperation within 6 years. So this multi-centered trial found that a staged surgical approach involving the initial correction of the aortic arch obstruction, followed by a delayed AVSD repair, was improved survival, less morbidity, and fewer planned reoperations. But the presence of at least moderate left AV valve regurgitation tended to be higher in the neonatal repair groups, and that also would contribute to their worse outcomes. Although this is a 2-stage approach you would think might lead to more time in hospital, they didn't actually have a significant difference in the post-operative ventilation time, the period of time in the intensive care unit, or period of time in hospital. And the costs of the second operation could be offset by the lesser frequency of unplanned reoperations in the complete neonatal repair group. So this is some data which is pretty hot off the press from Hannah Belsham-Rebel, one of my colleagues. And this really shows the period of time when David, myself, and Janner were working together, doing children who had got atrioventricular septal defects and coarctations, hypoplastic aortic arches. We were concerned at that stage that we had a 50% mortality rate. And what we were doing in this period was we were doing an arch repair, plus we were adding a pulmonary artery band to the arch repair at the same time. And you can see that 50% of these patients ended up dying, or perhaps even higher, if you remove those 2 partial AVSD patients. Then an arch repair plus a band in a common AVSD has an even higher mortality rate. Now, but then we decided to have a look. We changed our practice really in 2020, and this was probably really led by my colleague Janner Selly. And we decided at that stage that we would do an arch repair, and then at a later date, depending on the child's clinical condition, then we would add in the pulmonary artery band. But the other interesting thing is, look, we've got 14 patients in a 3-year period or 2.5 period. So there seems to be more of these patients coming through to the service for some strange reason. And a significant number of these patients have got trisomy 21, and most of them are complete AVSDs. I think there's just in this group, there's just 2 partial AVSDs. You can see on that patient 3 from the bottom, the birth weight of 1.8 kilograms. That child I put on bilateral pulmonary artery bands, and then at 77 days of life, went back, took off the bands, repaired the aortic arch, and then placed a pulmonary artery band. And that child is doing well and awaiting a complete repair at some stage in the future. But the interesting thing to note is that the mortality for this staged approach, doing an arch repair, then a band, then a repair, a complete repair of the AVSD, was at the present time is running with a 0% mortality rate. But some of these patients are still quite unwell. Like the first patient is in palliative care because she's just got a very small left component to her AVSD, her left side, her left atrioventricular valve, and she's got severe AV valve regurgitation. So this is, I think, very interesting work. It's something that we will have to publish, but we're giving a snapshot of what it looks like at the present time. So really, in conclusion, for neonates with atrioventricular septal defects and arch obstructions, when compared with a single stage neonatal repair, a staged approach is associated with improved survival and lower morbidity. So thank you very much, and thank you for allowing me to speak before lunch.